All right. Welcome, everyone. And a big thank you to Dr. Amin for coming today to share information on respiratory care. And I was just telling her that I love her title of Changing Landscape of Respiratory Care for SMA. It is a world of information that's coming in and like a snowball running down a hill, more information gathered. So it's wonderful to stay on top and be the best you can be. Dr. Amin has been a great advocate for the SMA community and working together with our other physicians in Canada. And we thank you for everything you're doing for the SMA community. And I'd like to welcome you. One moment before the bottom here, in case some of you haven't been to the other meetings, there's an interpretation button. We have interpreters speaking. So if you speak French, just click on the French and you will see the entire meeting in French. All right, with that, thank you, Dr. Amin.
No, thank you. Thank you very much, Susie. It's an honor to be here today. I always love speaking at patient and parent conferences because you often learn, I often learn so much from my patients every day. So it's nice to be able to give back and also share sort of the lessons that I've learned over the years. The first thing I want to say is I'm more than happy, like I would like this to be as informal as possible. So although we're on Zoom and it's talking into a screen, please, if you have a question, don't be shy to interrupt me. I actually welcome that because I hope that as we go through, we can have some discussion, because at the end of the day, I want to make sure that what we're covering today is really what you need. And as I always learn from patients, that what I think my patients need is often not what they need. So please, if you have questions as we go along, do not hesitate to interrupt. I'll apologize in advance if I don't see your hand raised or if I don't see the chat. But if people could help monitor that for me, that would be great. And even if you just say, hi, Reshma, I just have a question, please go ahead and do that so we can make the next hour that we have together as helpful and as productive for all of you as possible. Does anybody have any questions before we get started? Okay, I'll take that as a no. And like I said, if you have any questions as we go along, just don't hesitate to interrupt. So I'm delighted to be here to talk to you about respiratory care for individuals who have spinal muscular atrophy. And I think the one thing that I'll say first off is that with the changing landscape and the era of disease modifying therapies, I think we are all learning together. So often we have more questions than answers because the future is so incredibly bright. And I think that the field has advanced so much in the last 5 years that it's absolutely astounding. And it's such a pleasure to be able to be part of that. So our learning objectives for today are to start off with talking a little bit about how spinal muscular atrophy affects the respiratory system. Then we'll review the respiratory management of spinal muscular atrophy. And again, before 5 years, that's sort of where my talk would have ended. But now we have so much more to talk about. So I'll talk a little bit about some of the real life data that's been published recently, looking at the disease modifying therapy impact on respiratory outcomes in individuals with spinal muscular atrophy. We'll highlight what the limitations are of the current literature and sort of where we need to go next. And then I'll present a revised approach to how we're thinking about caring for individuals with spinal muscular atrophy currently. So just as a review for many of you, when we think about the breathing system, we think about this normal state. And in the normal state, we have respiratory load on one side, and then we have central drive, which comes from our brain and down from our central nervous system, plus our breathing muscles. And in individuals who have spinal muscular atrophy, because of the underlying genetic disease, they develop weak breathing muscles, which results in this imbalance of this previous balance. And so now the respiratory load is higher, And although the central drive to breathe is really ramping up to meet those needs, it's activating the respiratory muscles, but they just, despite this increased activation, are just not able to ramp up to meet that increased load. As a result of this imbalance, we can run into trouble during the night when we're sleeping, and also trouble with coughing and clearing secretions, which we'll be talking more about. When we learn about spinal muscular atrophy in medical school, the one thing that we're always taught is the big impact that the weakness in the breathing muscles has, in particular on the chest. And so traditionally, or I'll say now historically, because this is not necessarily the reality now, historically, because of the relative weakness of the intercostal muscles, which are the muscles between the ribs, infants who were born with spinal muscular atrophy type 1 had what we described as a bell-shaped chest. Because of the weakness, they weren't able to expand the chest when they're breathing in and out as much. And they often develop what you can see here on the screen, something that we call a PEctus deformity, which is a sign that there's been increased work of breathing over time in a child who has a very compliant, meaning flexible chest wall, and as a sign that these infants were working harder to breathe. And when we think about how weak breathing muscles affects overall respiratory health, this is sort of the pathway that I just want to guide you through. So we start off here with normal breathing, and before newborn screening and disease modifying therapies, we were never meeting children sort of at this sort of side of the graph of the figure. We were really meeting children who were sort of already halfway through this figure or even on the other side. So this is really exciting that we have the opportunity to meet these children and infants much earlier before they have any symptoms at all. So you can start off with normal breathing, and then because of the weaker muscles and the development of the weaker muscles, you could have a weakness with your breathing muscles when you breathe in, when you breathe out, your bulbar muscles, which are your throat muscles, as well. And as a result of that, you can have trouble with your swallowing and your coughing. So your healthcare team may be recommending assessments for those different things. You can develop trouble with coughing, and as a result, you have an increased risk of pneumonias and chest infections. You can have difficulties with your breathing, and you're going to have trouble with your breathing at nighttime first. And then that can progress to daytime trouble and having higher carbon dioxide levels first at nighttime and then in the daytime. But like I said, we used to meet most of the children sort of when they're already through this pathway, but now we have this incredible opportunity to meet children before they've even necessarily entered into this pathway. So how do we think about checking the breathing system, or what's our approach? So I've broken it down here on this figure into sort of some of the questions that you'll be asked, or some of the things that we think about asking, what we look for when we examine you or your child, and some of the tests that we do to help us better understand the breathing system. So at a clinic visit, you might be asked about what are the symptoms of sleep disorder breathing. So that's sort of an early sign. There might be trouble with breathing and sleep, although I'll say that oftentimes there are no symptoms. This is just something that we may find. We'll ask about recurrent infections or admissions to hospital. What are your secretions like? Do you have secretions on a regular basis? Do you have phlegm that you can spit up on a regular basis? Is there any trouble with breathing and swallowing and choking on foods? And is there any shortness of breath, either with activity or at rest or with speaking? And how do you do with colds? When we think about the physical examination, we'll be checking oxygen levels, carbon dioxide, let's go back here. Oxygen levels, carbon dioxide levels, the breathing rate, how hard you're working to breathe. Other things we're looking for is how strong your voice is, how strong the cough is. We're looking at the chest shape overall, if there's any curves in the spine. And then we're listening with our stethoscopes at the air going in and out of the chest, and also doing an examination of the heart. And then in terms of testing, you may hear your clinical team talking about blowing tests or pulmonary function testing, measuring peak cough flows or how strong the cough is, doing specific muscle function tests like MIPS or MEPS or SNP, doing sleep studies, having you see an orthopedic surgeon for a check for the spine and the scoliosis, sending you to an occupational therapist to assess the feeding, and then also potentially having a nutrition or a dietitian consult to review weight. Before I go on any further, I just wanted to ask any questions so far about any of that? No, good. Okay. So with that in mind, I've broken down, respiratory management into a couple of different buckets. And so if we have evidence of signs that the respiratory system needs support, your team will be introducing airway clearance, and we'll talk more about what that means shortly, or different types of ventilation. A big part of respiratory health is also ensuring that other systems and the breathing system are working together well. So we want to make sure that there's adequate lung growth. So how do we do that? We have to make sure there's adequate weight gain. We want to make sure there's no gastroesophageal reflux where gastric acid can go into the lungs. We want to make sure the reflux is controlled. If there's significant scoliosis, that also is another stressor to the breathing system. So often children will need braces and then have to go to orthopedic surgeons to consider scoliosis surgery, same with teenagers and adults. And then again, making sure that swallowing is good, such that to prevent any aspiration of food into the lungs. In addition, we want to think about also preventative things. So vaccinations. What can we do to keep children and older adults healthy? So the pneumovax vaccination, the COVID vaccination, RSV prophylaxis for the younger infants and toddlers. Another important aspect of what we think about is when individuals with SMA need to undergo a general anesthetic or have a surgical procedure. So we have to work closely with our anesthesia colleagues and the surgical teams to make sure that we've done everything we can to optimize you or your child for success for that procedure. So just to touch on non-invasive ventilation, so this is the mask that goes over the nose or the mouth to help with ventilation or clearing carbon dioxide. It'll also help with preventing collapse of the upper airway or obstructive sleep apnea. And there's sort of three main buckets of how this may be prescribed. One is if there was an admission to hospital for a pneumonia or an infection, it may have been started in hospital to help support breathing. The second is it may have been prescribed to you or your child or discussed as an early prophylactic reason, and we'll talk about that. So that's in terms of chest wall remodeling. Or the third is if you or your child had a sleep study and it showed that there was evidence of sleep disordered breathing. And now, of course, with disease modifying therapies, it's not just about starting the therapy sometimes and titrating settings with growth. It's now quite exciting that now we're able to be weaning settings as well. So I just wanted to talk a little bit about the use of Bipap for what we call chest wall remodeling. So in the first 3 years of life, your chest wall is very, very compliant. And so if you have weak intercostal muscles, which is what happens to individuals who have spinal muscular atrophy, then the chest will not be able to expand as much and is more likely to develop that chest wall deformity that you had seen on the previous slide. This is a slide courtesy of Dr. Zielinski, one of my colleagues in Quebec. And we've learned previously from sort of the old SMA, I'll call it, that if we start Bipap early And if we use big span pressures of sort of a difference between the top pressure and the bottom pressure of about 12, that we can help prevent some of that chest wall deformity from happening. And so this is just a slide to show this is a child who had SMA type 1, and you can see that with really good high span BiPAP, this individual has not developed that, that PEctus deformity as was in the original picture. So your clinical team may be talking to you about starting BiPAP early for chest wall remodeling, and this is the rationale behind that. We also may be recommending to start non-invasive ventilation or BiPAP after sleep studies. So for those of you who haven't had a sleep study or haven't had a child who's had a sleep study, let me just review what this entails. So I'm a pediatric doctor. So for pediatric patients, it's an in-hospital test. Usually it's an outpatient procedure, but the test is about 8 to 10 hours of recording. So usually you come in for the test around 8 o'clock or 9 o'clock, and then you go home in the morning around 6 o'clock in the morning. We collect all kinds of information to understand sort of how your body is breathing and sleeping effectively. So we have these leads that go on, which are EEG leads. So we can see if you're awake or asleep, what stage of sleep you're in. There's a plastic cannula. It looks like an oxygen cannula that goes in the nose. That is measuring both the carbon dioxide you're exhaling out as well as airflow. We have another little pressure transducer that sits just under the mouth, and that also measures airflow. You'll have to wear a belt. One goes on the chest and one goes on the belly, and that measures how fast you're breathing, the effort of the breathing. We videotape the whole thing, and then also you'll wear an oxygen saturation monitor and another carbon dioxide monitor. And then we also put leads on the legs to look for leg EMGs or kicks. And so with all of that really robust information, we get data that looks like this on a screenshot. So to you, this looks like a lot of squiggly lines, and I'll admit this looks like a lot of squiggly lines to me too. So these top squiggly lines that you can see here, where it says EEG, those are the brain waves. In blue, the EOG, these are the eye movements. CEMG is the chin recordings. We measure your chin muscle tone. In red, we have our ECG here. This is the leg EMG. And then here is where we measure airflow. Effort is measured by the chest and the abdomen belts. And then this is our carbon dioxide tracing and our oxygen saturation tracing. So this on the screen represents about 2 minutes of sleep, and we have 8 hours of recordings to go through. And then based on this information, we can diagnose trouble with collapse of the upper airway or obstructive sleep apnea. We can diagnose central sleep apnea. That's where there's a pause in breathing, but no breathing effort. Or we can diagnose nocturnal, meaning night, hypoventilation, meaning not enough ventilation, so trouble clearing carbon dioxide. And individuals with spinal muscular atrophy are at risk of developing all of those 3 kinds of sleep disorder breathing. Just very, very briefly, when we give the breathing machine, we're giving pressures during inspiration and expiration to keep the airways open. It helps to give the breathing muscles a break. And we usually adjust the settings during either a sleep study or based on clinic visits and looking at the downloads. A couple of precautions is we try to avoid feeding at the same time through a gastrostomy tube if possible, but it's not always possible. We want to make sure we've optimized your reflux control. We want to make sure oral secretions are managed, because otherwise, when you wear the mask and you're giving a high pressurized air, you might lead to sort of aspiration of those secretions. And then we often recommend having some home care support, because it's a lot of work and it can be challenging when you start BiPAP for the first time. Okay, this is just parts of a BiPAP setup, just for those of you who haven't seen it before. Number 1 is our on-off button. Number 2 is our mask. We keep the mask in place using this headgear, number 3. Then we have the tubing that joins the mask to the machine. Number 5 is the humidifier. So this is to ensure that air that gets delivered is warmed up and humidified to make it more comfortable. Number 6 is the filter. For those of you who have Bipap, to remind you to check those filters and change them and replace them. And then number 7 at the back is a little oxygen connector. So if you need to use oxygen with your Bipap machine, that's where you connect it. There's a lot of text on this screen. I don't expect you to read it, but just if you want it as a reference, you can just screenshot it or take a picture. It's just a review of sort of where we start for the different settings and what the different settings mean. Okay. So let's talk a little bit about some practical things. So this is something that we struggle with very frequently. You know, help, my child won't wear their Bipap. So first things first, you're not alone. So it is a journey often to get individuals to get acclimatized to use their Bipap. First things, you know, the one thing to highlight and say is you're not alone. The second thing is, you know, go slow and keep the experience positive. So usually we try to fit individuals with the mask first in the clinic, so while they're awake, and then we'll even try turning the air on to see what that's like. Even just to get a child to wear a mask at all could be a struggle, so it may take weeks or months to even get to that step. Then we work on wearing the mask at home in the daytime, and sometimes, you know, it's too much to get a child to wear the Bipap just in the sleep lab, so we may need to have a short admission to make that work. In addition, as if you're a patient or you're a family or a parental caregiver, you know, don't be afraid to ask for help because you need to sleep too. And I think we really appreciate that. So there are resources that sometimes we can advocate for to help you, like home care nursing or attendant care. What are some of the common Bipap issues? So I think the biggest issue is that with the interface that has to sit tightly to the mask, you can get skin redness. So make sure the mask isn't too tight. So sometimes if there's leaking, our reflex is to tighten the mask, but sometimes we can over tighten it. So make sure you can put 2 fingers under the headgear at all times. Recheck that the mask is still fitting. So especially for children who are growing, they may have outgrown it. And please reach out to your team early. As soon as you see some redness on the face, reach out to them so they can check to see if you need a new mask, because masks should be replaced every 6 months, to see if you need some skin barriers, or maybe to see if there's another mask that you could try that has different pressure points. If the mask is leaking, a lot of the same as I mentioned above, we'll often try another mask that goes over the nose. Maybe we'll add a chin strap, or then we'll try thinking about a mask that goes over the nose and the mouth to prevent the mask leak. Nasal congestion is a very common complaint. Often the humidifier setting needs to be adjusted, or sometimes we need to prescribe nasal steroids. Often nosebleeds can happen. So again, we have to make sure the humidifier settings are appropriate. Sometimes you can have stomach bloating, because although the air for Bipap is supposed to go into the airway, some of it inevitably can go into the belly. So if you do have a G tube, it can be vented. And sometimes having significant stomach bloating can be a sign that there's significant mask leak. So maybe we have to revisit the fit of the mask. We also want to make sure we've optimized reflux, because again, although the air is supposed to go in the airway, sometimes it goes into the belly. So if you have some reflux, sometimes using Bipap can make things worse. And then just a plea that we really, healthcare, you know, the clinicians really want you to bring all the equipment to your clinic visits so that we can check the mask fit, check the tubing, check the filters, trial the therapy on you if we want to make adjustments. I know it's big and heavy, but there's so much value in being able to try it on you if you bring it in person. Many of your clinical teams will do data downloads of the Bipap. This is really valuable for us to understand how you're using the therapy and is it effective. So this is just a screenshot of the download. Importantly, we check the settings that you can be on. We look at the leak. from the interface, because if there's a big mask leak, none of that pressure is getting where it needs to get. We look at the volume that you're breathing in and out. We look at how fast you're breathing. We have these rough measures of the apnea hypopnea index that we look at, and then we look at usage. So here, of course, is a patient who had really excellent usage, which we were, happy about. And then here's another patient where you can see this is the usage: on, off, on, off, on, off, on, off. So really struggling here. So this information helps us figure out how best to help support you. Any questions about Bipap before I move on and we talk about airway clearance? Okay, we'll keep going. So airway clearance is sort of the next big bucket of therapies that you may be using or you may have heard of. So when we have a normal cough, how do we do that? We take a big breath up to about 60 to 80% of our lung capacity. We then close our glottis, which is our vocal cords. We then pause there, and then our expiratory muscles will contract. We open up the glottis, and then air comes out and secretions come out with it. So if we have inspiratory muscle weakness, then we have trouble taking that big breath in. If we have bulbar weakness, we may have trouble closing those vocal cords and then trouble rapidly opening them. If we have trouble with our expiratory muscles, we're not going to be able to forcibly expel secretions. And so the net effect is that really we're left with a weaker cough. And that is where airway clearance treatments come into play. So this table shows some of the most commonly used types of ways to help with cough clearance. So and probably the most common one used in the realm of SMA is cough assist. We'll focus on that one, but just to mention, glossopharyngeal breathing is that frog breathing, that sort of gulping to help with increasing your lung volume so that you can forcibly cough. Lung volume recruitment is done, I think I have a picture of a video of it here, just so you can see what it looks like. And so you can see this dad is using the bag as this patient is taking a bigger breath in. So this is helping with the inspiratory, the inspiration to take that big breath to our total lung capacity. And then that abdominal maneuver also helps with the exhalation. Cough assist therapy is a mechanical device that we can use. It applies a positive pressure, then shifts to a negative pressure. And as you know, it can be delivered using a mask, a mouthpiece, a trach adapter, or an endotracheal tube. What are the benefits of cough assist therapy? It can increase the strength of your cough. It can help remove secretions. It can help prevent lung collapse. It can increase that chest wall range of motion. And it can also increase your speaking volume. So who gets it? So you or your child may be asked to do some of these different tests. So objectively, we can measure the strength of your cough. We can measure respiratory muscle strength. And those are some of the criteria to have governments in different provinces be able to prescribe that therapy, or I should say to be able to dispense the therapy. This slide just shows at a high level how we do the therapy. So it's just for your reference. I just want to touch on this because this is something that we're often asked. So there's different modes, and what do those different modes mean? So there's a manual mode where the pressures are set on the unit, but the device is manually controlled by the user. In auto mode, this is probably the one that's most commonly used. It's automatic, so we set the pressures and the times of the machine will automatically deliver those. There's also cough track, which is available in the auto mode, and the machine essentially will synchronize the timing of the cough assist therapy with the patient's efforts. And then in the cough assist for Canada, which is different than in the US, we also have this option for oscillation. So we can set the frequency and the amplitude as well as the different cough assist settings. And the idea here is we use oscillation to help enhance clearance of secretions. How do we give it? Most patients use it twice a day. Some use it much more frequently than that. You'll hear people talk about cough cycles and sets and treatments. So a cough cycle is sort of the insufflation and the exsufflation, so that one cycle. And then one set is usually 3 to 5 cough cycles. And then one treatment is usually 3 to 5 sets. You may need to do this much more frequently with viral infections. It's typically best to do it before meals. It's easiest to do it on an empty stomach, and also at bedtime. And if we get often asked, is it okay to take my meds? And it's okay to take your meds. This is another high-level screenshot that you can screenshot or have for your reference, just in terms of what the different settings mean. So from a practical perspective, this is what a typical prescription can look like. So on the E70 Cough Assist machines, you can set 3 different prescriptions. Sometimes we use this is sort of where you start, and then we work up to maximal settings once you're fully sort of acclimated. Sometimes we have, this is the setting, preset 1 is what you use when you're well, preset 2 is what you use when you're unwell, and then preset 3 might be manual. So your healthcare team will work with you to make a prescription that sort of works the best for you or your child. Okay, so a couple of practical questions. So this is something we often get asked. So the treatment can't be working because there's no secretions that are being brought up during therapy. That's okay. So just because you don't see secretions, it doesn't mean that you or your child does not need the therapy or it's not working. So we like routine cough assist because it creates a routine for the patient and the child. It helps to keep the parent's skills up so that if you do need to use it in the case of emergency, you're completely comfortable to use it. It helps because you're giving that positive pressure. It's going to help open up the airways and improving gas exchange. It may also prevent you or your child from getting sick and needing to come to hospital, because if you could help move the secretions and clear them proactively, it may not progress to being, you might not progress to becoming so sick to need a hospital admission. And then when you do have a viral infection, you may be needing cough assist more, because we know that when you have a viral infection, you produce more secretions, but also your breathing muscles may get weaker in the middle of an infection. So you might need more help to clear things. Okay, a couple clinical tips about cough assist. So don't forget to check the tubing and the mask in your mouthpiece regularly for cracks. You can run into trouble with that and develop some leaks sometimes. For the mask, if you do your cough assist therapy with a mask, you can see in this picture here that there's this seal around the mask, and this is a little place for you to put a syringe in and inflate it. So continuously check that that little rim is appropriately inflated. Otherwise, when you do the therapy, the pressure is going to leak out and it won't be as effective. And then lastly, bring your equipment to clinic. So it's really helpful to your team, because then we can download the data to check the peak flows, to check for leaks. We can review your technique. We can check the settings and we can adjust them as needed. And also you may need the therapy while you're there for a long day at the clinic. So please, we always strongly advocate for you to bring your equipment. The next slide here is really showing what a cough assist download looks like. So it's organized into for this readout is organized by day. And then what we get from this is you can see what this is like: 1 week, 2 weeks, 3 weeks. And we can, when we in the clinic, we can set the period that we want to look at. And we can look at how you're using the cough assist. So we can look at how many treatments you're using per day, how many sequences, how many coughs, what the minimum and the maximum peak cough flow are. So just sidebar here, when we can measure peak cough flow as a way to decide who needs cough assist or not. And we have certain thresholds below which sort of indicates there's a weak cough. Then in addition, we can measure your peak cough flows from the cough assist. So we can see if we need to be optimizing settings. Is there a big leak? And that's why the peak cough flows are falling. So it helps us be a bit more of a detective to ensure that the therapy that you or your child are getting is actually effective. Okay. Briefly, just touching on infection prevention and surgical support.
Reshma.
Yeah.
I just wanted to say that for 10 years now, SMA Canada has been funding cough assist machines for individuals who live in provinces where it is not supported and funded by the province. We were at a conference many years ago, and the speaker said, everybody in the room, which had several hundred people, put up your hand if you have a cough assist machine. And many hands went up, and they said the ones that don't, your hand should be up. It should be absolutely everybody in this room. So for that reason, I did want to say that I want everybody to know that this is something that SMA Canada does to support its patients. And, you know, just wanted you to be able to share that too.
Yeah, absolutely. That's thanks for sharing that, because yes, until 2014, when Ontario was able to start providing cough assist provincially, we used to have to fundraise with each and every patient to help raise the funds to be able to purchase that. So of course, thank you so much, Cure SMA, for that support. And I think I saw there was someone's hand that was raised.
Jan Defosse had his hand up.
Did you have a comment?
Jan, did you have a?
Yeah, no, it's just for answer to Susie. I think she has to raise her hand if we have a cough assist.
Oh, oh, I see. You were raising your hand because you have a comment.
Oh, that you don't have
Maybe
one?
I've got a question. What's your thing about the knowledge the parents or the patient developed with the ears? Because sometimes they use, like her son used a Bipap for 9 years now. Do you think you have some possibility in the future for the caregiver and the patient work maybe a little bit more together to be day-to-day following in the treatment, like to make the sleep study? Often in the hospital, it's not the better place to be naturally. So maybe it will be possible to do it at home and make some adjustment on the Bipap directly.
Yeah, that is no, thank you for that excellent question. So the question was, you know, in the future, can we, you know, do we think we'll be able to manage the Bipap adjustments and sleep studies at home? So that's an excellent point, because that's the same thing that all parents and patients feel, is that, you know, the hospital is really not the home environment. And so we have tried to do what's called level 3 sleep studies. So it's abbreviated sleep studies at home in neuromuscular patients with end-tidal carbon dioxide. There's definitely limitations. And so we weren't able in that study that we did to show that it was as effective as the in-hospital sleep study. Then we just finished another study just before COVID, where we used transcutaneous carbon dioxide in the home. So we had a respiratory therapist go to the home, set up a transcutaneous carbon dioxide machine, and compared that to what happened in the sleep lab. And unfortunately, that was challenging because just because transcutaneous carbon dioxide is so finicky to titrate overnight. However, what I would say is that now I think that we are getting really good at, and the Bipap downloads are much more sophisticated than what they were, that we're getting really good at being able to make adjustments to the Bipap settings based on the downloads. And we can now do integrated oxygen recordings with download data. And so I do think that the frequency with which we'll need to be doing Bipap titration studies can be stretched out to give you a break from always having to come to the hospital. So thank you for that excellent question. I think I see Jeff Sparks raised his hand.
Thanks, Dr. Amin. I did have one quick question around the cough assist modes. You referred to the automatic and then the track mode. When would we indicate switching between the two? Because I know I've had mine on auto for years.
Yeah.
But I'm wondering if maybe I should be using the track.
That's a great question. So Whether or not you can use the cough track, I think needs to be made by your clinical team, really to see if that you're able to synchronize. So some patients, based on their degree of respiratory weakness, are just not able to synchronize. The machine can't detect that sort of breath initiation of the patient. And sometimes it can. So we'll try it when we set someone up on cough assist. We'll try the auto mode. We'll try turning on the cough track and just see if the machine can synchronize with the patient's effort. And if that's the case, then we'll turn the cough track on. But if we can't synchronize, then we leave it off. So maybe just at your next visit with your care team, just have them try that to see if you're able to synchronize with it. It'll make the therapy more comfortable for you. It's similar to thinking about one of those synchronized modes of ventilation that detects when the patient's making an effort. It's kind of the same idea.
Is the end result the same though, Reshma? Or what's the benefits of the tracking over?
I think that the benefit is really just it's going to be synchronized with your effort. And so that way it ensures that I think you have the best chance of success. Otherwise, we do our best. For the auto, it's going to give the inspiratory and the expiration. It's just with the cough track, it helps it be more comfortable. I don't know. It's a good question, Susie. I don't know of any studies that have looked to see if auto versus auto with cough track to see if auto with cough track is more effective. It's an interesting question to look into, but I think from my understanding, that really is about comfort at this point to synchronize it.
Okay. Does anybody else have a question about cough assist? Just unmute yourself and feel free to ask.
Okay. I wanted to just, so along the lines of thinking about vaccinations, and because we all have the pandemic on our brain, one of the things that often my patients ask me is that, are they more at risk of getting sick with coronavirus than somebody who doesn't have a neuromuscular disease? And the question is, up until recently, we really didn't know because the data is so limited. I just want to share, this is one study that I was able to find. And this is from the Spanish group. And what they did is they looked at their whole registry of children who have neuromuscular disease, and then sort of reflected on their experience with the coronavirus infection. So it's a small number, so it's only 29 children, but I just wanted to share with you, this is how they broke down their coronavirus infection. So into mild, moderate, or severe. And of those 29 children, 11 of them were completely asymptomatic, 15 had mild infection, and 3 had moderate infection. And so who were these children? So out of the 29 children, the mean age was 8.4 years, ranging from 4 months to 17 years. You can see a large proportion of the 29 actually had spinal muscular atrophy. So 21% SMA1, 17% SMA2. And this, I think, is what I wanted to highlight, is that of all of these 29 children, 26 of them did not require a hospitalization. 3 of them did, but only 1 of them needed to be hospitalized in the intensive care unit. And what I did is I looked at this, this study and compared it to sort of what we know about larger scale coronavirus infection in sort of, larger pediatric populations, including with healthy children. And the numbers really aren't significantly different. So if anything, I think this is somewhat reassuring. Of course, the numbers are so small, the data still is quite limited, but it doesn't seem like, based on this small study from the Spanish registry data, that really children with neuromuscular disease are at significantly increased risk. Now, what we don't know from this is, it looks like only 2 of these children were on steroids. But we don't know if a larger proportion were on steroids, if that would be the same outcome. It's just something I wanted to share. Okay, so pre 5 years ago, that's really where my talk would have ended. But now we have so much more to talk about. So with disease modifying therapies, and of course, you all know this better than I do, and you all know the trial data much better than I do because you've had eloquent neurologists review this in significant detail. But what I wanted to do in the remaining time is just highlight some of the real world data that we have about the respiratory outcomes for individuals with SMA who've been treated with nusinersen moving forward. So this was a nice study that looked at 118 patients. And of this 118 patients, they were all children. They followed them forward for about 2 years. The median age at the time of getting the first nusinersen dose was 42 months. And if you see in this table 4 of those individuals, so T0 means like time 0, 22% were spontaneous breathing, so needing no breathing support. 26 were needing Bipap for less than 10 hours, 24 for more than 10 hours, and 46 were requiring invasive ventilation. And in this table, you can see their outcomes when they followed them forward at 300 days. And so I found this table a bit hard to follow, and I thought this figure was a little bit easier. So I'm just going to share the figure with you. So in this figure, the gray means this gray means they were stable, light gray means they got better, and then black means they deteriorated or they died. So if we look at the spontaneous breathing group, we can see that 9 of those 21 stayed the same. 12 of those 21 either deteriorated or died. Of the cohort that had non-invasive ventilation using it less than 10 hours a day, 18 of those 24 were stable and only 6 deteriorated or passed away. If you use an NIV for more than 10 hours a day, there were 3 that did in fact improve. 15 were stable, and then only 4 deteriorated. And then if you're on invasive ventilation, none of this cohort died, and the 42 were stable. So the bottom line here from this real world data is that SMA patient, if we look at SMA1 patients who were treated, the biggest benefit really appeared to be stability of the disease, but unfortunately still a significant proportion of patients may still deteriorate. This study is published from the Australian group. It was just published in May, and it looked at the effect of nusinersen on respiratory function in pediatric SMA types 1 to 3. And so what did they aim to study? So they wanted to look at the effects of nusinersen on respiratory function. This was a prospective study, so they followed this cohort forward. So it's a really exciting study that they've done. And they followed them forward between June 2018 to December 2019. And they looked at their lung function and also their sleep studies. So what did they find here? Well, first of all, who are these patients? So just to give you a sense, this lets you know what type of SMA they had. So 7 had SMA type 1, 12 had SMA type 2, and then 9 had SMA type 3. And the age at first nusinersen, you can see here, was 0.42 years of age for the 1s, 9.7 years of age for the 2s, and 7.5 years of age for the 3s. Now this slide here shows rate of decline in percent predicted FVC. So FVC is your forced vital capacity, and it measures the amount of air that you can breathe out after you take a big breath in. So it's really a robust measure that we use in SMA to look at lung function. And these results are so exciting. So if we look at the total group, we looked at their lung function 2 years prior to treatment. And in the total group, there was a drop in lung function of minus 5.94% predicted per year. And then at the end of, or during that first year of treatment, that dropped to only being a drop in lung function of 2.56. And really interesting is if you look and subdivide the 2s and the 3s, you can see there's really this impressive change from minus 5.86 in the 2s to minus 1.03 in the 2s on treatment. You may ask, well, where are the 1s in all of this? And because to do FVC, you need to be at least 6 years of age. It likely is just related to age, that the children weren't old enough to be able to do that testing. So this is exciting. In the real world, not in study trial conditions, in the real world, treatment with nusinersen for 1 year improves lung function. So how did this impact on obstructive apnea hypopnea index and sort of what was the sleep study perspective of this? So here on this figure that you can see, what the authors did is they looked at their apnea hypopnea index, which combines the obstructive apnea index with the central apnea index to give an overall index. They looked at sleep studies sort of at this baseline and then 1 year after treatment. And what you can see is the majority of the indices are going down, and a lower index is a good thing. So we want the numbers to go down. For the SMA types 2s, it looks like it was a bit of a mixed bag. And for the 3s, again, it was a reduction. Now, the one thing just to note is they sort of bundled obstructive and central together. One wonders if they separated out, would they have seen a difference? So really exciting. I want to share with you some work that we've done at SickKids looking at our cohort of SMA1 patients receiving nusinersen. Just want to highlight my colleagues, Dr. Jackie Chang, who's another respirologist in our long-term ventilation program, and then also Dr. Lena Shao, who's one of our sleep fellows. So we followed forward the cohort of patients that we have, and the median age of receiving nusinersen was 4 months. And the median age of having the baseline sleep study was 9.6 months. And so of our cohort of these 8 patients, you can see 5 of them are spontaneously breathing, so not needing any kind of ventilator support, and 3 of them had a tracheostomy and ventilation. And what we found was that overall, we found that there was of these children, there were significantly more events in REM compared to non-REM. And if you look here at the middle of this figure, the central apnea hypopnea index seems to be overall quite elevated in these infants, whereas that's not so the case for the obstructive apnea hypopnea index. So just to review, central apneas or central apnea hypopneas are consistent with central sleep apnea, and obstructive apnea hypopneas are consistent with the diagnosis of obstructive sleep apnea. So in our cohort of these infants, central events were really the predominant finding, and we found that in these infants, they had an elevated central index. Another interesting finding, although such a small cohort, but really exciting and interesting nonetheless, is that we found that if you had a higher CHOP-INTEND score, it seemed to be associated with a lower central index. So again, higher CHOP-INTEND score, the better, and lower central index, the better. So you can see how sort of we have these 2 groups sort of falling out here. So these were our preliminary findings that despite treatment with nusinersen, unfortunately, when we followed these patients all forward, all these patients ended up requiring ventilation. Central apneas appear to be the most frequent finding. And then we found this association between higher CHOP-INTEND scores and lower central indices. So what are the possible explanations for this? It may be that neuromuscular weakness might affect control of breathing along with these low oxygen levels, or that there may in fact be a primary central mechanism that's conferred by SMA that we haven't previously appreciated before. So lots of questions and lots of work still to be done to better understand this. So next I wanted to talk briefly about our experience with newborn screening in Ontario from the respiratory perspective. So newborn screening in Ontario started sort of mid-January of 2020, and really exciting to hear that there's national collaboration funding for newborn screening in Alberta, Manitoba, and Quebec. And these are just the early findings from the respiratory perspective. So there's been, of these infants who have been identified by newborn screening, these 3 have undergone sleep studies to date. And let me just take you through this table. So patient 1 has 3 copies of SMN2. This patient received nusinersen by 1 month of age and then Zolgensma by 6 months. Patient 2 has 3 copies of SMN2, received nusinersen at 1 month and Zolgensma at 5 months. And patient 3 has 2 copies of SMN2, received nusinersen at 3 weeks and Zolgensma at 3 months. So if you follow patient 1 forward, at 1 month of age, this patient had an obstructive index of 14 per hour, So normal is less than 2 per hour. So this is quite elevated. And also a central index of 10.7 per hour. So also normal is less than 5 per hour. So this is also quite elevated. Interestingly, when you go from 1 month to 3 months, you see this change where the obstructive index decreases, but the central index actually really significantly increased. It tripled. And then by 6 months of age, the obstructive index now is in the normal range, and the central index is in almost the normal range. And of course, just to show you, that nusinersen was given around this time, Zolgensma was given just before. So it'll be really interesting when we do follow-ups at 12 months to understand what these indices are looking like. If we go and look at patient 2, so here they just had a sleep study at 3 months of age. So again, obstructive index is quite high, central index also high, but a big change with a reduction in the obstructive index to normal by 6 months, but persistence of this central index, which we're seeing. And then in our third patient, at 1 month, no obstructive events, but again, these significant central events. So this is all quite fascinating because these are 3 infants identified by newborn screening, all of whom were asymptomatic initially when we first met them. And so it'll be interesting to know, what does this mean? What changes are we going to see over time? And hopefully we'll have more to share with you by next year on that. I just want to highlight one of the things that we're seeing, especially in our local population of infants with SMA who have been treated with nusinersen, is we're seeing significant scoliosis. So this is work done by Dr. Hernan Gonorowski, who's our lead neurologist in the SMA program at SickKids. So this is some work that he's led, which shows that all of our infants with SMA that were treated with nusinersen before 6 months of age have all developed scoliosis. And interestingly, what we're seeing is that they all had initial improvements in their CHOP INTEND scores of muscle function, but 2 patients actually dropped, so got worse with the last dose. And it's interesting to see that these appendicular scores, so the CHOP INTEND, you can break it down into axial score and appendicular score. So it's interesting to see that the appendicular scores improved, but the axial scores have sort of stabilized or dropped, which are really the ones that seem to be correlating with the Cobb angle. So because of this significant scoliosis that these infants are developing, Dr. Gonorowski has led a program to start doing Garcia Bracing for these infants. So they're fit by orthotics. It's quite an intensive process, but we are following these patients forward, and hopefully we're going to be able to achieve some stability with their scoliosis progression with this bracing. So I have this X-ray up here to show that really the scoliosis is something that we need to be tracking for these children over time, because although the motor function seems to be improving, it seems to be that the scoliosis is definitely a lot more severe than what we traditionally had seen. So one of the challenges ahead is understanding the impact. I apologize, this shouldn't just be on the child, the impact on the child, the patient with SMA, and also their families. Because as we talk through, respiratory care for these patients, we can't forget that with the disease modifying therapies, there's so much that we ask of you all and your families just to do these different therapies. And then on top of that, we're adding respiratory technologies. And so we want to understand what impact there is for that. So we are setting out to do a study where we're going to be interviewing children with SMA and their parents about their experience with the diagnosis of SMA, as well as the treatment with all of these disease modifying therapies. So we can understand their experience with the diagnosis, the treatment burden, what we ask in terms of using respiratory technology. So we're aiming to interview 15 to 20 parents and 10 to 15 children between ages 8 to 16. We're hoping to start in October 2021 once we have REB approval. And I just want to acknowledge that funding has kindly been provided for this study by Cure SMA Canada. So this is my last slide, and what I want to leave you with is that we have more questions than answers for you right now. As you can see, we're still scratching our head trying to understand those sleep findings in that newborn screen cohort. This is what the recommendations for respiratory assessment were based on the SMA guidelines from 2018. And what I've added in green here is that maybe we need to be thinking about things differently. We need to be thinking about starting an IV more aggressively for chest wall remodeling or scoliosis to see if that's going to be effective to prevent the curve from progressing as quickly. Because with disease modifying therapies, we see improvements over time. We need to be getting some baseline data at every sleep study and also be constantly evaluating patients for weaning. And then even for patients who are on invasive ventilation, we still are seeing improvements. So we have to be conscious in doing daytime sprinting trials as well. So this is all things that we need to be thinking about. Nothing is set in stone, but it is such an exciting time for these children and these families. So the path ahead is exciting. We still have so many questions that need to be tackled. And I think this changing landscape is exciting, but also challenging at times because we don't know what the future is going to hold and sort of what this new trajectory is going to look like. But what we do know is that this new trajectory is much, much more successful and positive than prior to all of these therapies. So with that, I want to end, and I thank you very much for your time. I know we're a bit out of time, but if you had any questions, I'd be more than happy to hear them. And also, please feel free to email me or contact me at any time.
Thank you. That was amazing, Reshma. Thank you so much. I have a question. I was wondering if you have any patients receiving risdiplam and what your findings are.
That's a great question. So I think that there are 2 patients that have been switched over to respond. I am not aware of any of the long-term findings yet to share with you, but I know that in our practice here, the patients that are being switched over are really the older, more severe patients, and often those where it is such a challenge to be doing the nusinersen injections because they're having to go under a GA with fluoro to do that. So this is an easier option. And then also those patients that were switched over, I think we're having declining motor function skills as well. So probably the neurologists are better positioned to comment than me, but that's sort of my limited experience with it so far.
I am aware of, that there is data supporting bulbar function improvement for patients on risdiplam. So I was just wondering if you personally had any experience with that or.
Yeah, not yet.
Not yet. Yeah. I mean, we're on the cusp of hopefully seeing more patients receiving it.
Yeah.
Does anybody else have any questions for Dr. Amin? Please just unmute yourself and go ahead and ask. Yeah, go ahead.
Yeah, I would like to know about the fact or the pertinence to wear abdominal belt with the Bipap. It's something we see in the Facebook community in France. Often they wear abdominal belt, and it's help to solicit more the thoracic than the diaphragm.
Yeah, it's a good question. I think the diaphragmatic belts, the negative pressure ventilators, I think those are all viable forms of support, I don't have any experience with those to date, but I think that, sometimes things that were very common before come out of favor, then sometimes will come back in favor, right? So because there's always more than one way to achieve a goal, right? So, but yeah, sorry, I don't have any experience to share with you, but yeah.
And do you have some, is it possible, you think, is it possible to do more than just keep the capacity? They have some exercise or some exercise to make to expand the ability, the respiratory ability?
Yeah, I think so. So I think one of them is, you know, it's all about trying to remodel that chest and inflate and recruit. So I think that bi-level is an excellent way to do that. So I think focusing, we always want to have a big change between the top and the bottom pressure of at least 10, usually 12 in an individual with SMA. And then the other thing is that you also have cough assist, and because you can give, so what we do sometimes, because we want to maximize recruitment, is sometimes when we do the cough assist and the last set will end on the inflation. So instead of just ending sort of with the deflation, you could always end with a positive pressure to help recruit.
Thanks for your answer and the presentation.
All right, thank you so much. Is there anybody else that have questions? We'll take one more and then we'll close out the meeting. No, you were very thorough. Thank you so much, Dr. Amin, on behalf of all of us, and happily we will share the recorded session, and other patients can also address what was said in this meeting. So thank you so much.
Thank you.
I wish everybody a great day. See you at the next meeting. Bye. Thank you again.